Hello, my name is Philip Blatt, and I'm a fourth-year medical student at OHSU.
Today I'll be talking about Pellagra's Pitfalls, Mimickers, and Metacognitive Missteps. So to start off, Pellagra was first described in the 18th century by a Spanish physician, and up until the 20th century was a major cause of death until our food supply was fortified with niacin. The disease itself is caused by an intracellular depletion of niacin and presents with classic syndrome of dermatitis, dementia, diarrhea, and death if left untreated. It poses a unique diagnostic challenge because despite having a well-known clinical syndrome, it's still an incredibly rare disease in the Western world. It has mimicking conditions, including psoriasis and systemic lupus erythematosus. So the case, we have a 62-year-old man with a history of alcohol use disorder. He's coming in with a 1-month history of a progressive rash and reports from his roommates of incontinence and confusion. His labs are unremarkable. And on physical exam, he's got this photo-distributed rash with areas of hyperpigmentation and desquamation, which you can see in the images here on the poster. All 4 of his extremities, neck and face, are affected, and notably his anterior and posterior torso are spared. His hospital course was notable for a dermatology consult in the ED, which established a presumptive diagnosis of pellagra. At that point, he was started on empiric niacin and topical steroids. And over the course of his hospital stay, his rash drastically improved, his delirium resolved. We were not able to document any episodes of diarrhea. He was discharged with a 4-week course of niacin. However, 6 weeks post-discharge, his rash returned, and the rash was biopsied by dermatology, and the pathology showed evidence of psoriasis. And now his rash is controlled on high-potency topical steroids. So clinical reasoning fallacies in this case. The base rate fallacy. So we did not consider how rare pellagra is and how common psoriasis is in prioritizing the differential. An atypical presentation of psoriasis is more common than pellagra. There was also diagnosis momentum. So the dermatology established the diagnosis of pellagra. We trusted it, and we sort of ran with that momentum. And then confirmation bias. We looked for findings to confirm pellagra rather than findings that would suggest something else is going on. So maybe he's actually improving on steroids rather than the niacin. So this case demonstrates the difficulty in the diagnosis of pellagra. And in reality, a minority of patients present with the classic triad. The recurrence of his rash, the pathological evidence, and then current control on steroids suggests that the rash diagnosed as pellagra initially was in fact an atypical presentation of psoriasis. So take-home points here, most cases are diagnosed by dermatologic manifestations, making the diagnosis difficult due to mimicking rashes. This case also highlights diagnostic reasoning pitfalls, including base rate fallacy, diagnosis momentum, and confirmation bias. And then psoriasis is common and can have an atypical presentation similar to pellagra and can be well controlled with topical steroids. I'd like to thank the residents that worked with me, Dr. Taslin, Dr. Kim, Dr. Rutland, and Dr. Burnett. Thank you all for your help in this presentation. Thank you for listening.